Static CT scans only map anatomy. Nuclear medicine maps transit, allowing us to visualize the continuous flow of physiological processes in real time. Normal renal physiology splits into two distinct operational pathways. Exactly 80% of kidney function is driven by tubular secretion, while the remaining 20% relies on glomerular filtration. To diagnose specific renal pathology, we have to isolate one of these two pathways. We do this by engineering radiotracers designed to be processed exclusively by either secretion or filtration. Once the selected tracer is administered, we initiate a continuous dynamic scan. We watch the radiopharmaceutical travel through the renal system in real time. This journey breaks down into three distinct phases. First, arterial blood flow, then cortical cellular uptake, and finally, collecting system clearance. By tracking these pathway-specific agents over a set duration, we plot out functional anomalies, distinguish mechanical obstructions from benign dilation, and identify failing transplants. Nuclear GU imaging provides a mathematical map of invisible biochemical transit times. This diagram models a single nephron. To evaluate the glomerular filtration rate, or GFR, we need an agent that travels straight into this blue pathway, the glomerulus. Technetium-99m DTPA is our exclusively filtered agent. The tracer molecules easily pass through the glomerular filter, allowing us to accurately estimate GFR. There is a technical caveat. About 5% of DTPA binds to proteins in the blood. Because these bound particles are too large to pass the filter, relying on DTPA slightly underestimates the true GFR. To estimate effective renal plasma flow, we switch to the alternative pathway. Technetium-99m MAG3 is actively pumped from surrounding vessels directly into the proximal tubules. Because MAG3 bypasses the passive glomerular filter, it performs much better than DTPA in patients with severely impaired native renal function. Active tubular transport allows the kidneys to concentrate MAG3 highly efficiently, generating a diagnostic signal even when overall renal blood flow is compromised. The major exception to dynamic functional scanning is technetium-99m DMSA. This tracer binds slowly to sulfhydryl groups in the renal cortex and stays there, making it the standard for static structural imaging of the cortex itself. Every measurement relies entirely on the biochemistry of the chosen tracer. If you pick the wrong chemical proxy, the physiological measurement is invalid from the start. This graph represents the macroscopic result of a 30-minute dynamic scan. This is the time activity curve. Within the first 20 seconds of the scan, the kidneys should enhance symmetrically as blood arrives from the aorta. This line peaks between 3 and 5 minutes, marking normal cortical uptake. Next comes the clearance phase. As the tracer leaves the cortex, the curve slopes downward. In a healthy patient, tracer counts will drop to half of their peak value between 7 and 10 minutes. We quantify any delays in clearance using strict ratios. A normal 20-minute to 3-minute count ratio is less than 0.8. A normal 20-minute to peak ratio is less than 0.3. To get accurate counts, the system must correct for background radiation. The technician manually draws a region of interest, or ROI, around the kidneys, and another in an adjacent space to establish a baseline. The most common technical error is drawing the background ROI over the liver or spleen. Both organs naturally take up some background tracer, which artificially inflates the subtraction baseline and skews the entire differential function calculation. The time activity curve transforms subjective visual brightness into an objective mathematical standard for assessing renal function. When clearance is delayed, the immediate diagnostic problem is figuring out if the collecting system is physically obstructed by a blockage or simply dilated and sluggish. This chart illustrates the reservoir effect. A massive, structurally compliant renal pelvis pulls the radiotracer. It mimics an obstruction on the graph, but there is no actual back pressure preventing flow. To force the distinction, we use the Lasix challenge. Exactly 30 minutes after clearance begins, we administer a diuretic. A structurally compliant system will flush out when overloaded with fluid. A true obstruction will not. A normal, unobstructed system responds rapidly. Greater than 50% of the tracer will wash out within 10 minutes of administering the Lasix. A true mechanical obstruction fails the challenge. The washout takes longer than 20 minutes, with the graft remaining rigidly flat despite the diuretic overload pushing against the blockage. There is an indeterminate zone where washout takes between 10 and 20 minutes. This usually happens when the reservoir effect is so extreme that even the diuretic cannot rapidly flush the massive volume of pooled fluid. Without the pharmacologic stress of a diuretic, anatomical compliance completely obscures the diagnostic truth of the baseline time activity curve. We apply a similar stress test logic to vascular issues, specifically renal artery stenosis. A kidney suffering from poor perfusion masks its own deficit by physically constricting the efferent arteriole. This creates artificial back pressure, forcing filtration through the glomerulus to maintain a normal GFR. We break this autonomic compensation with the captopril challenge. Administering an ACE inhibitor stops the efferent arteriole from constricting, causing the filtration pressure to drop. Because DTPA strictly measures glomerular filtration, breaking that pressure gradient causes a sudden, measurable decrease in both tracer uptake and flow. If we use MAG3, the reaction is different. MAG3 relies on tubular secretion. When the pressure drops, the tracer gets stuck, showing up as abnormal, prolonged retention within the renal cortex. The captopril study proves that baseline flow is an unreliable metric until the kidney's chemical defenses are pharmacologically stripped away. In the immediate postoperative period following a renal transplant, interpreting these kinetics becomes a matter of organ survival. This graph breaks down the most critical diagnostic challenge, separating acute tubular necrosis from acute rejection based entirely on kinetic data. Acute tubular necrosis, or ATN, has a distinct signature. The new kidney maintains normal arterial perfusion, but cellular excretion is significantly delayed, resulting in an elevated 20:3 ratio. Acute rejection presents as a catastrophic failure of both metrics. The graph shows profoundly poor blood flow alongside delayed excretion. We also use the tracer to identify post-surgical fluid leaks. Urinomas pool the radioactive fluid, appearing as hotspots outside the bladder. Hematelmas and lymphoceles contain no tracer, presenting as cold, photopenic defects pushing against the anatomy. Isolating perfusion timing from excretion timing is the only definitive way to separate a temporary ischemic shock from a terminal immunologic attack on the graft. Nuclear genitourinary imaging ignores structural mapping in favor of pure functional logic. Diagnostic accuracy begins with the tracer. You must match the exact chemical proxy, whether driven by tubular secretion or glomerular filtration, to the specific clinical question at hand. Once the temporal scan begins, we have to assume that baseline physiology is a compensatory mirage, hiding underlying deficits. This is why systemic stress tests like the Lasix and captopril challenges are mandatory. They break physical and chemical compensations, forcing the true pathology to the surface. Whether diagnosing a benign reservoir, a stenotic artery, or a rejecting allograft, the time activity curve provides the undeniable mathematical footprint of the disease. Mastering these kinetics allows the physician to trace invisible biochemical failures long before they manifest as anatomical damage. In nuclear medicine, time acts as the ultimate diagnostic arbiter.